just a quick agenda of what our plan is this morning. We're probably going to run out of time. We have a lot of slides, as you can see, 90 some odd slides or something, 85. But I'll give you, you can take these slides back with you. There's information that we may breeze over. You can take it back and do further training or something on it, or keep it for your staff or anything like that. But we want to just do another exercise in a few minutes that sort of gets your mind thinking about HIPAA and FERPA in the SBHC context. And we're going to go over that in just a couple minutes. And then I have a series of scenarios that are pretty basic that you've probably seen all the time at your SBHCs, but we just want to go over some of these common scenarios of when HIPAA and FERPA might apply and just sort of issue spot through those. We'll go through a little bit more detail of FERPA and HIPAA, some of the rules and some of the exceptions, and then an application of FERPA and HIPAA to SBHCs. We'll use Omaha as our example of just how we did it. This is just one example. And then we'll revisit some of the scenarios that we're going to talk about in a few minutes and just see if we have spotted all the issues. And then if time permits, we'll have some questions and further issue spotting. I sort of wanted to qualify at the get-go that, with FERPA and HIPAA, really these two laws depend on exactly how you are set up. I was thinking about it on the airplane yesterday, and there are like a list of 20 different facts that I came up with on a piece of paper that could change whether or not HIPAA applies, whether or not FERPA applies, what you do in this, what you do in this context, depending on how you're paid, how your SBHCs are set up in terms of, is it a school service? Is it a private service that's just coming into the schools in your four walls? So a lot of the answers to your questions will depend on that. And we're going to go over one of the more common setups and then apply the laws in that case. But if you have questions throughout, we're going to take a couple breaks. You can either ask them in front of everyone, or if you want to come up and ask us, that's fine too, because I find that when I do these trainings, whether it's at a hospital, whether it's in front of a group of school administrators, I don't necessarily have a black and white answer, and that it's good to issue spots so you can go back and say to your administrators or to your other folks at your facilities, well, what do we do? They mention this word, authorization. Do we do that? What do we do in terms of consent? So I'm not here to pick apart each and every one of your processes and say you're doing it wrong. It's just that it's good periodically to revisit the rules and figure out, well, do we need to change something? Is there a simpler way to do this? And things like that. So, just as a little bit of background, obviously schools and healthcare providers make for a very unique relationship. You've got a lot of confusion around HIPAA and FERPA. Folks tend to now use the word HIPAA very loosely. I know I was talking to just some friends, and she said, well, my aunt has cancer, and didn't want anybody else in our family to reveal that she has cancer, and so now she's sending everyone a letter saying you're violating my HIPAA rights by telling everyone that I have cancer. I mean, nice use of the word, but the family members aren't covered by HIPAA unless they were providing her services and billing for it. So, I mean, people are using that word. The scary part is that all you have to do is Google HIPAA, and you can find out very easily where to go to report a violation to the federal government. I was telling Anna on the way over here, I mean, every day I get a call from someone, and I get a voicemail when I get to work that says either we've got an investigation going on or we think we might have violated HIPAA. The case that I was supposed to be on a call right now talking about was one anesthesiologist, solo practitioner, provides services at a hospital, one guy, one doc shop, is accused of telling his wife something about a patient, small community, got around to the patient. She's now reported it to the federal government, and he's being investigated. So it's not huge health systems that are subject to all of these HIPAA enforcement actions. It's everybody. If the government thinks it's bad enough when they get one of these reports, they will come knocking, and it is very time consuming to respond to them, and you have to pull a lot of stuff together in a very short amount of time. So thank you for coming today and realizing how important this is. The part that gets tricky is all of the ins and outs of HIPAA, really. That's the law that's going to apply most of the time. in the common SBHC context, and you all probably have policies and procedures that talk about the different uses and disclosures and exceptions and when you can disclose the information without authorization, and that's good, but you know, there are so many different scenarios and it's so fact specific. But again, it's very good to constantly issue spot it right now, knowing that the patients are out there, the families are out there, and all they have to do is call the newspaper and accuse you of a HIPAA violation, and it's out there, and you're having to do PR, you know, cover-ups or responses, and a lot of times it didn't even happen, or it's not a HIPAA violation, but you're responding to the newspaper. And if, you know, we've experienced this in Omaha, parents are very concerned about students' information, whether or not it's covered by HIPAA or FERPA. They're worried about who's seeing their information at the school district, and they don't want it floating out in the cloud. And they're very quick to, again, call the newspaper and say, look, we think this is wrong, and it blows up, and then you've got a huge story out there, and the school board's not happy, and the administrators aren't happy, and they're calling us and trying to figure out what's going on. So it becomes a very confusing process if you don't pay attention to these issues up front. So I'm sure that many of you have already addressed these when you formed your SBHCs, and that you continue to address them, and that's again part of why we're here today. So that's why I have the periodic training is important. Then we do want to go through some best practices and real life examples. We'll share with you a few of our processes that we have, and then we'll sort of just discuss as a group what you all do in terms of some of these issues. So just a couple of questions, and I have some free giveaways that I brought with me, so audience participation is encouraged. So as school-based health providers, I guess the first question is not on here. Just by a show of hands, how many of you have an SBHC that is like this model, I guess, where you have an elementary school or a school district, and the school district does not want to be in the business of providing health care. They completely contracted or arrange for these services through another outside provider, where these providers are not school district employees. They're outside employees. Okay, that's what I thought. That's I would say the more common example. And then the other alternative is where the school district is in the business of providing health care beyond counseling and beyond school nurses, and where they actually arrange, they may even bill for some of the, that's not, you don't have that? Okay, good. That's by far the less popular model. So second question, do you discuss privacy and confidentiality upfront with students, with parents, with teachers, administrators? I guess, can someone share how that process goes for a discussion if a student comes to the SBHC, whether it's for a runny nose or something else? What is the conversation like with the student who shows up, the patient? Anyone willing to share a recent conversation they may have had?
So, depending on the age of the student, I talk to them about how, as a fact that they have the right to consent to treat in the state of Oregon, that information is kept private and confidential from their parents. I go over the exceptions to what that would be, because it tends to be things like, I specifically go over like the abuse reporting, but I also let teens know that I'm going to inform their parents with hopefully their permission if they talk to me about active suicidal, homicidal ideation, or self-harm, just because parents will have a cow, they don't know. And I do let them know that the records are not in the school, and that it's kept separate and private from their academic records and things, because I've had kids concerned that somehow colleges are going to find out that they came to see me, which is an interesting concern they have.
Yeah. Okay, good. What about a conversation between the SBHC providers and teachers? Have you been involved in any of those where teachers, I know a lot of times, want to call up and say, you know, what did you see this patient for?
Yeah. Well, there's times when teachers will say, I'm worried about a student and I want them to be seen, and you explain to them that, you know, I'm more than happy to see them, but I can't share with you the results unless I'm given permission.
Okay.
Situations like that.
Has anyone had a conversation, I'm sure you have, with the teacher that is really pushing for that information back, and how does that conversation go?
I go, you know, I'm really sorry, but we're not allowed. It's my license, and I want to be able to continue to have a clinic here for the students. So
Okay.
I can't share that with you.
Okay. And I see law enforcement in the room. So what about if law enforcement is calling up and demanding the information? Has anyone had that conversation? That's an issue that we deal with a lot with hospitals, where there will be a motor vehicle accident or something, and they'll show up demanding information. Has anyone had?
We're not demanding.
Okay. Or you're going to show up with an active investigation report, right?
I don't want it.
Yeah. Good. Good answer. You don't need a flashlight, so don't give him a flashlight. Okay. And then same thing with school administrators. So, if they're doing a project like Anna's going to talk about this afternoon, like research or evaluation, a lot of times they'll want to have data on, maybe how many students did you see? What did you see these students for? Have you had to have that conversation that says, look, we'd love to give you that data to do some sort of a research project, but we may be limited? That's probably a less common thing that comes up unless you're really involved in the research or the evaluation piece, but we are going to talk about that because especially if there's a community organization behind you, or if you're trying to get grant funding or support, a lot of those funding sources will want to see, well, where is my money going? What are the outcomes? And that can be difficult. It's not easy to just get that information and link it and then make it public. There are limitations on that. So the second question, or the other, I guess the third question here, have students expressed concern about disclosure of information to parents, the schools, or other healthcare providers? I know you mentioned colleges finding out, but what are the students concerned about? I mean, I guess it probably depends on age, and if they're getting an STD test or some mental health services, but are the students concerned? Good. So, why privacy? We all know this. Obviously, that it can influence whether someone seeks care, when they seek care, where they seek care, and it can influence the patient-provider relationship. So if the student is not confident that their information is going to be kept confidential and private, they may not show up, they may not tell you everything. I mean, we all know these issues. It's very common. So with that, I just want to do another quick exercise. We're going to just issue spot and word spot quick. We have the handouts with the little interactive exercise. What I'd like you to do is pretend like we're opening up a new SBHC. It's the model that's up here, where it's the school district or the elementary school. It's not a school service. It's the separate provider. Armstrong Healthcare is coming in to provide services. You are on the task force to identify the privacy and confidentiality related to access, use, and disclosure of education records and health information. So just think about what are the issues of the information flowing from the school district to the SBHC, and then vice versa, from the SBHC back to the school district. Just throw out some words: consent, authorization, things that you think would be an issue that you would need to go to either your clinic administrators or to your school administration and say, look, we might need to have a policy on this, we need to address this. So just take your experience as SBHC providers and as school administrators and office administrators and everyone, and just figure out what are the issues that you've come across. This is helpful for us as we go through this to just see that everyone's on the same page, and then it also helps, I think, you all just to again issue spot and remember that it's more than just a HIPAA authorization, that there are other issues involved. So just spend like 5 minutes with your table and just brainstorm. They can be one word, they can be more conceptual of just, what are you going to need? Why do you need here's some questions to think about. What information do you need? Is the information protected by FERPA? Is it protected by HIPAA? Why do you want to share the information with each other? Who are you going to share it with? What are the privacy and confidentiality concerns? Do you need consent under FERPA? Do you need an authorization under HIPAA? When are you going to get that consent or authorization? Are you going to get it from the parents? Are you going to get it from the student? Where are you going to store the information? You have a lot of records. Do you store it on paper? Do you store it electronically? Do you store it back in the school's information system? Do you share users, between the two information systems? And then how will the information be accessed or disclosed? Are you doing things on paper? Are you calling the school? Are you entering stuff in the school record? So just think about some of those things for a few minutes and see what you come up with. Here are some of the words that we came up with in preparing the presentation. We also heard a lot of these as we were walking around, sort of eavesdropping on your conversations. But like I said, these are really good conversations to have, because sometimes at your organizations you don't have time to sort of go over all of these scenarios, and days like this are a good opportunity to sort of revisit some of these issues. So, we came up with things like protected health information, law enforcement, SBHC providers, FERPA, research, teachers, consent, administration, program evaluation, STDs, treatment purposes, parents, medication, attendance records, consent, education records, HIPAA authorization, enrollment forms, consent to treat, emergencies, business associates, EHRs, EMRs. That's just a few things to think about. What else did everybody else think about? And we'll sort of talk about issues. They can be words, they can be broader issues. Let's just have a little bit of interaction. Yep.
One of the things I see missing up there is billing and insurance reimbursement.
Good. We're making a little list of other things that we saw over here too, like injuries and just other words that we picked up on. So billing is good. Any others?
Yes.
Just ongoing training and education about how to communicate with the school-based health center, from teachers, administrators, who goes through who and who is appropriate to email or not email. So it's just really about communication and training about all of these issues.
Yeah, really big issue. Omaha School District is very large. We have the same issue. I go to the superintendent's office. They don't know how these things even operate. We got a new superintendent. He doesn't have a clue how these work. Their lawyer in-house doesn't know what FERPA consent they have. I mean, I did it for them, so I know what it is, but she doesn't know it. So it's that same thing. It's, when someone comes to the superintendent's office or the legal counsel's office for a request, they sort of say, well, I mean, maybe this sounds okay. We don't know. We don't know what the information's doing, because there's been so much turnover. And, we trained on it 5 years ago, but there hasn't been anything since. And as you know, working in healthcare, there's a lot of turnover. Good. What else?
Mandatory reporters.
Good. Big issue. Anna and I were talking about this last night. I don't hear about this. I hear about it a lot working with hospitals, but I don't hear about it in the SBHC context. I think it's because all of the licensed providers who have the mandatory reporting obligations, they're so well versed in this, and they do it. So, I'm not here to say you're doing that wrong, because you all know the rules and your licensure obligations for that. But that is very important, and given the patient population that you're seeing and the types of potential abuse that you're going to see, that is very important. What else do we have? Yep.
Crisis intervention, when an outside party, not a part of the SBHC or the school, comes in to provide mental health crisis services.
Good.
And who are we operating under between HIPAA and FERPA?
Good. Yep.
Educate parents between the difference, the health center and the school. Because there's a lot of confusion on that. They think that you are an extension.
Exactly.
And because we were discussing, like, so-and-so told me that he's going to see so-and-so, and you need to answer, like, I cannot confirm or deny that I will see your kid.
Yeah. So how do you guys address that out here of, making it known that the school is not in the business of providing health care? Is it in the enrollment forms? Is it through parent education sessions, or is it just sort of case by case?
We are working on that and getting more streamlines and clarification on how we're going to move forward. But it has been a very interesting
I
learning curve.
bet. That's very interesting.
My situation's a little different because we are a private nonprofit school, therapeutic school that provides mental health services, but we're all employed by the same agency. So we're just one agency. But when a kid comes in for services, for school services, because they're referred by their school districts, parents fill out an enrollment form. But separate from that, so that's like school stuff, information, immunization, all that. But separate from that is a very extensive, what we kind of stole from language, consent to treat that goes more extensively into what those mental health services look like within the milieu.
And I guess on that issue too, for all of you that are in the schools not providing such specialized services, but when you get the consent, do you get a very broad consent up front that includes everything, potentially, you know, immunizations, or is it still pretty limited and you're calling the parents when you do, you know, a flu shot or something like that? I mean, what are folks doing in that regard?
I can share, like what we do with our school-based health centers in Omaha is that at the beginning of the school year, children, when they get their packet in the mail from their schools, there is an enrollment form. They fill that out. However, the language is that they're consenting to treatment. However, our practitioners always get a follow-up consent for their, because the providers belong to the 2 federally qualified health centers. They do either a verbal consent over the phone and send home a second consent form for consent to treat once they see the child. So it's like a double consent.
And it's different. We were talking with the consultant in Chicago last week, and they do basically the exact opposite. They get the most broad consent they can up front that lasts while the kid is in the school district, so you know, a very long time, so that they never have to call the parents. I mean, that's a pretty aggressive approach, but it's one approach that they've taken.
For us, our consent has to, that first enrollment form that's done, if they're in elementary school, it's good for the duration of their enrollment in elementary school, and when they switch to middle school and then high school, they have to do a new enrollment form. So we would like to move towards one, but we do also have a population that moves between schools as well, school districts.
What's your minor
Copies of those consents?
I'm sorry?
I'd love to see a copy of those consents.
I'm sure we can share those.
We can see if
Yeah.
the school district will share it. Omaha Public Schools, you have to understand more background, is extremely proprietary about anything. Education, records, everything. So we can probably get a copy of that because it's basically a public document anyway. But
Minor consent law.
so minors can consent to STD testing on their own.
What do you consider a minor in?
19. It's not, the age of majority is 19 in Nebraska. 19.
Oh, no.
So we're on the a little bit more on the conservative spectrum in Nebraska. So yes, I don't want to get into consent much because that's really a whole nother day-long presentation, and that is really specific to state law and a lot of providers' choice as to when they get informed consent and consent to treat and FERPA consents based on your school district's sort of policies. So I don't want to spend, I don't really want to spend too much time on that topic because I don't have the best way, and I can't tell you what to do under your state laws and your school district policies of when to get these consents, but it's good to just think about when you're getting them. Yep.
Isn't it the whole reproductive health seeking care national no age? Isn't that
Title 10. Yeah, I mean we have those clinics in Nebraska where that is obviously a different requirement, but the age of majority in Nebraska under state law is 19.
Our school-based health centers do not provide, per state legislation, they are not allowed to do family planning.
reproductive health care is all the STI testing
We
and
can
all
do
that.
We
testing
can do that.
and we can do pregnancy testing, but we can't.
We have
like, if
we
they
have a
positive
state law
test.
that minors can seek STD testing. It's not specific. It doesn't include HIV, but most providers take the position that it includes HIV, and there's no permissive disclosure to the parents in our state law. I mean, there's no specific statement that the providers can permissively talk with the parents about that. So some providers just, if the child will not agree to that, the providers just simply won't see them many times, and they'll send them to a Title X clinic, or they'll send them to another clinic where they know that the providers will do that. But a lot of providers, again, being a little bit more conservative state, will not treat unless the child authorizes disclosure to the parents. So what other issues do we have?
We were looking at it as an elementary school and realizing that there's times in which then a 7, 8, 9-year-old would be potentially needing care without parents' permission. And our agency has a form that parents can fill out that allows a non-parent guardian to bring a child in for treatment. So we were recognizing that that would certainly be a critical need, since the child would be too young to consent to their own treatment.
Right. Good. Okay, how about one more, and then we'll move on. Yep.
We talked about the flow of information between law enforcement, schools, your school-based health center, even down to our crisis team that comes out, and if we work in silos, you know, that's not very, very helpful. And if something happens at night where all these other places are closed and it's just law enforcement, how we share that information to the school district so that they can do safety planning within the schools, and then that would trickle onto everybody else.
Good. Good. And we'll talk about this later, and I'll ask you for more examples of what you do. But in terms of, you know, like just for example, in Omaha, our providers do have access to the school's information system for some very limited records. So just be thinking about how you, or if you allow your SBHC providers access to that, or if everything's made, you know, verbally or fax. That's the second half of the presentation. So just quick, some scenarios we want to go through. We'll just discuss these just verbally, and then we're going to revisit these after we go through the HIPAA and FERPA part of it. But scenario number one, the school nurse calls and refers a student to the SBHC. The SBHC treats the student. The SBHC needs to communicate information back to the school nurse about medication administration instructions. So what do you think? Permissible? What are we talking about here? Exceptions? Are we talking about HIPAA, FERPA? Anyone want to volunteer just to think? You can say what you would do in this situation. I'm not going to say whether it's right or wrong right now. We'll just hear what are your thoughts on that. Yep.
Well, I get it for the school nurse. I get it. HIPAA and FERPA communicated to her. HIPAA communicated to her.
Okay.
Other ways I do it to the mom and dad or
Okay.
both.
Okay. Thank you for volunteering. Sort of a little variation on that. The teacher contacts the school-based health center and wants information from the health center, you know, on details on medication, or if there's instructions that this child needs to follow, or if there are side effects of these drugs. Would you talk to the teacher? I'm seeing a lot of no's. Okay, good. Scenario number two, student cuts himself at school and is referred by the teacher to the SBHC. While at the SBHC, student states that he has a weapon in his locker and he's going to hurt teachers and other students tomorrow. The school wants to call, or the SBHC wants to call the school, parents, and law enforcement. What do you think? Good. Good response. Good. And actually, this is a very common question that we get from hospitals and clinics too, because you know, when HIPAA first came out, there was a very big tendency not to disclose the information, saying, well, we don't know what the permitted exception is here, but we'll talk about it a little bit later on. But there has been even advice from the federal government about saying, yes, we want you to be able to call law enforcement, but there are still some rules behind it, and you probably have policies on this, and you've probably been trained when you can do it. It's not just a free-for-all. Scenario number three, this is a hard one, and this, I have to warn you, depends a lot on your state law, and we could talk about this one for probably an hour, but a minor consents on her own to STD testing at the SBHC. The minor pays cash for the service up front. She gets home, the parents see a prescription, are furious, they call the SBHC demanding information about why she was there, what this prescription is. Do you talk to the parents?
No.
Okay. Again, we'll revisit this, but a lot of this is a hard one because it does depend a lot on your state law, which I am not well versed in because I'm not licensed here, so I can't give you opinions on your state law. Scenario number 4, this goes to Anna's expertise.
Because in Omaha, we've actually done a grant around obesity, and we did not have this issue, but in our community, because we have a lot of philanthropy, there are a lot of grant programs that come out. Can everybody hear me over there? So what if you're in a school-based health center and your school principal finds out that the Children's Hospital has an obesity grant that they're going to award, and they think it would be a really great idea to build the case for why they should get this grant award to do some obesity prevention and intervention in their school? We need obesity data on your kids, and if you're putting that in as a diagnostic code, can we look at the obesity rates and kind of match it up with our academic records to see if there's some tie between academic outcomes and obesity? Can you give us that information?
Hearing a lot of conversation, and that's good because this is a very complex area.
It is.
It's good.
And we have up here the College of Public Health, so that's part of this, is to pull in an additional partner who's going to help evaluate the grant should you receive it.
Hearing things like IRB.
I saw a hand kind of go like this.
Yeah.
Can you pull, her response was, can you pull the data without student name?
Yeah. Because isn't HIPAA just personal identifying information? If you are assigning a number to it or a database.
What about FERPA?
I don't know.
Well, FERPA would do your state testing.
We'll get to that. But,
Results
you know,
if you use
we're going to talk
those.
about identifiers, what's an identifier in a minute, but I'll just give you a hint. Under FERPA, student ID is an identifier as part of your education record. And that's a lot, I mean, if you're going to try to link data, a lot of times you need, and there are ways to do this. We did it in Omaha, but Anna will go over that a little bit briefly this morning and more this afternoon if you want to come to that presentation about how use of that student ID is working. Scenario number 5. This is common. It happens. Every day I get calls on these situations, but SBHC provider, at the end of the day, goes home, stops at a gas station, has a whole bunch of paper records in the car, leaves the car unlocked, the paper medical records have disappeared, they're stolen. Now what? I heard no more job. That's okay, but again, remember there are rules under HIPAA of what happens in this situation, and it's going to be, for one, probably embarrassing because you're probably going to have to write the parents a letter telling them what happened. You're going to get a lot of calls, and these situations potentially shut down SBHCs where the public says, look, if this is how you're handling my records at a school, we don't want these in place. So number 6 is a freebie. One of my coworkers at work found the next slide, which we'll go over, but this should be clear. But this happens all the time. I get calls on this all the time. SBHC provider sees fellow SBHC provider treating a child. Provider number 1 knows the child's neighbors. Provider number 1 looks up the diagnosis, meets the neighbor for coffee, and explains the medical history and diagnosis. I mean, we don't even have to go over what's wrong with that, but this happens all the time. Last week I was dealing with a client, same thing. It was, got a call, and they said, someone in the community knew that I was pregnant. I have not told anyone. No one knows. Not family, no one. But how did someone come up to me and say congratulations? Clearly that was somebody at the hospital had been looking through records or had seen the patient and had told someone. I mean, you would think that these things don't happen, but they do everywhere. And it's still a huge problem. We're going to go over some examples, but this is what I wanted to leave you with before we take about a 5-minute break. One of my coworkers found this on a social media website. This was Blake Lively and Ryan Reynolds were having a baby recently, and they were at a hospital, and it was reported that they were having a baby. No one really knew, what they had named their daughter. So at the bottom, this is the report. It says Blake Lively and Ryan Reynolds reportedly have a daughter named Violet. Well, how did they find out? Well, there was this tweet from Sam, who worked at a hospital on the East Coast. It says, "Congrats. Glad to have you and baby girl Violet in our care." We see this all the time when the Kardashians go to UCLA, when kings are being treated at the Mayo Clinic, which is in our territory. You see this all the time. And you see tweets, you see pictures on Facebook, anything like that. So you'll notice this was at 9:29 on January 5th of this year. Minutes later, she changed her Twitter handle and said, I think, I didn't print out all of the responses that she got to the first tweet, but it was pretty obvious that she was going to be fired and that she should probably change her Twitter handle and do something about it. So this is probably the low point of the presentation where we get into HIPAA and FERPA. I don't want to spend too much time on it because you probably already have been trained on it and you know your policies and procedures, but it's good to refresh yourself. We're going to go over just some of the general privacy rights of both laws, who's covered, what information is covered, the uses and disclosures piece, because that's the hard part. That's, when you want to access the information and disclose it and use it, that's where you sometimes get tripped up. And then we'll go over some breach examples. I only do that because I do a lot of HIPAA training, and the breaches, you cannot dream up these situations. And it's good, and if any of you, God forbid, ever have a breach and it's reported to the government and they come and investigate you, one of the first things that they ask for is, were your employees trained on HIPAA and breach notification? And so you could be able to point to this session and say, yes, they were trained on HIPAA. We do have a good training program. They know about the breach notification laws, because that's where the enforcement around HIPAA is happening right now, is the breaches that are happening out there. So good training session on that. So we'll start with FERPA. I didn't include some of the other privacy laws, but privacy is nothing new. We've had the federal substance abuse counseling laws that have been around since the 70s. You have FERPA since 1974. You have state laws across the country protecting privacy and confidentiality of different information. I'm sure you get the statements in the mail from your banks, from your credit card companies, from your insurance companies saying, here's how we use your information, here's how we disclose it, here's your rights. So there's been a long history of an expectation of privacy and confidentiality of sensitive information. It's not just your health records, it's your financial information, it's all of that. And so that's, it's nothing new. And so I just want to talk about two of those specific laws and how they come into play in your settings. So FERPA is the federal law that protects the privacy of students' education records. It gives students the right to privacy by limiting the disclosure of certain records, and then it assures that parents and eligible students have access to those education records. So the question that you really have to ask yourself is, do we have an education record? We'll go over that definition in a minute, but like I said at the beginning of the presentation, a lot of what you do in the SBHC won't involve FERPA because a lot of you aren't getting education records. It's a little bit different when we talk more about our Omaha example. In that case, the SBHC providers do get education records, they get access to education records, but a lot of times in the most common SBHC scenario, you're not getting FERPA information and you're not putting anything back into an education record. So really you're only worried about HIPAA. And someone always asks, are mental health and behavioral health services covered by HIPAA? Yes. And if you do substance abuse counseling, that's a whole nother set of federal regulations that's more strict and stringent, and we unfortunately don't have time to get into those today, but that's probably okay. So under FERPA, parents have the right to access their child's education records, to have the records amended, And then the important part here is to consent to disclosure of personally identifiable information from education records, except as provided by law. So who does FERPA apply to? Probably most of you in the room. It's all public and private schools that accept federal funds. That basically gets in everyone, elementary, secondary, and post-secondary. You know, depending on how you're set up and how you get funding, you may not be subject to FERPA, but for the most part, most schools get some sort of a tie back to the federal government through grants or something, and that wraps you into FERPA. So the general rule, again, the educational agency or institution may not have a policy or practice of disclosing educational records of students or personally identifiable information from education records without a parent or eligible student's written consent. So what's an education record? It's records that are directly related to a student. They're maintained by the agency or institution. And then I've listed some examples there: grades, student health records, so if the nurse is entering information, comments made by teachers, psychological records, disciplinary records, special ed records, IEPs, things like that. Are most of your schools maintaining electronic education records right now? Okay. I mean, when I went to school, there was no electronic student records, but it sounds like across the country, that's how most of them are maintained on various information systems, and they're all set up differently to capture the information, you know, in different tabs, where depending on what your role is at the school, you may not have access to the student's entire record, and a lot of that is because of FERPA. I mean, do the teachers really need to know all of the student nurses' notes and everything like that? I mean, you may or may not have access just based on your role. So what's personally identifiable information from a FERPA standpoint? You have name, including parents and other family members. Personal identifiers, that's where you get student ID involved. That is personal identifiable information in an education record. Other identifiers: date of birth, mother's maiden name, address, and then this category at the bottom, this very broad category. Whoops, I flew through that. Broad category of information that alone or in combination can be linked to a specific student. So a couple of questions with FERPA. Like I said earlier, you have to ask yourself, if you're thinking about whether or not it applies, is do you disclose education records to the SBHC? Or if you're doing program evaluation or research, are you disclosing the student ID, student name, immunization records, nurses' notes, IEPs, things like that? Are you disclosing those to the SBHC? Do you know, just by some interaction again, is that happening? Is it happening either through access into the system or, you know, other communication? Is that happening? I see a head nodding yes. How does the information flow in your example? Okay, access to vaccine records.
Sometimes if we're doing like an independent education plan,
Mm-hmm.
we need to see for you know a medical. In this state, they have to have a medical evaluation too.
Mm-hmm.
So you might see some of the test scores that they've done
Okay.
in school.
Mm-hmm.
Also in the SBHC, we see that.
Okay. And what about attendance records or grades? Don't see that. Okay. Yeah, in Omaha we have access to that, but it's going to depend on what type of services you're providing, probably at the SBHC, of whether they need that information. And then what about information from the SBHC back into the education records? In our example, the SBHC providers will sometimes enter something into the school's information system that they saw the patient or that the child had an SBHC visit. I guess, does anyone want to share that, you know, what information is being shared back with the school and what makes it back into the education record at the school?
Or are you able to even edit or input anything into the school records?
Computers.
No.
You know, we give them the sports physical forms, we give them immunization records from our clinic.
Okay.
But they're entering that information into their system.
So that goes
manually entering
in a paper form to them,
Yeah,
or
it's
fax
paper.
or something?
It's paper.
Okay, good. Yeah, so that's, those are good things to think about. When you talk about FERPA consent, The parents have to provide a signed and dated written consent before the school may disclose those education records. So it's very specific, of course, of what has to be included, what records are being disclosed, what's the purpose, and then the parties to whom the disclosure is being made. So we'll talk about the flow of this, but just know that that's what's required in the consent. When is consent not required? To other school officials, to contractors, in very limited situations. This applies, again, more to what Anna's going to talk about in terms of program evaluation. But when you have a school official or an outside contractor that's performing a service that the school would do or could do, and that they just choose to outsource it, you may be able to disclose the information. Even if it's outside the four walls of the school, you may be able to disclose that information without consent, depending on the service that's being provided. And if it's, again, a service that the school could have done themselves, but they're just choosing to outsource that function. You think of something like legal services. Our firm represents the Omaha Public Schools. We, from time to time, will get information about either a lawsuit or an incident involving a student. The Omaha Public Schools could choose to have their own legal team. So this is something that they could have done in-house, but they chose to use us, so they're disclosing the information to us without a consent from the parent. So again, that depends on your school district policy on allowing contractors to do services, but just know that that's one situation where you might not need prior consent. Parents, other schools to which the student is transferring, this is similar to HIPAA, judicial orders and subpoenas, health and safety emergencies, and then organizations conducting studies on behalf of the school. That's very limited. There's specific types of studies that have to be done in order for that information to be disclosed without consent. But that's just a short list of some of the types of situations where you don't need consent. I included this slide, directory information, because a lot of times, the school will call the SBHC and say, I have a fourth grader who's coming to the SBHC. You obviously don't need consent from a FERPA perspective for these types of information that that might be considered personally identifiable, but it's not going to cause harm. It's not considered harmful or an invasion of privacy. If it's disclosed, this is name, address, telephone number, email address, photograph. You see when you go to a sports event, you'll see their height and weight. That's personally identifiable information, but it's considered directory information, so you don't need consent to disclose that. In terms of directory information, if you're going to do that, that has to be included in your FERPA notice. A lot of you probably, if you're on the school district side of things, you probably distribute this as part of the enrollment packet, where there's an annual FERPA notice, and that will talk about directory information. It may or may not say, we will call the school-based health center. I don't know what your FERPA notices look like, but depending on how detailed they are, you may have statements in that notice about talking with the school health centers. With directory information, you do have to honor opt-outs that parents or eligible students can exercise. And then again, check your state law, because you may have more restrictive laws about releasing school directory information. So that's FERPA. I don't want to get into all of the details of FERPA again, because I want to talk more about how this comes into play in the SBHC context. And then the bigger issue for most of you is going to be HIPAA, which is relatively new compared to FERPA and the substance abuse privacy laws. HIPAA was not originally, it came about as a portability tool so that you could take your insurance from one employer to the next, or if you were transitioning jobs so that you wouldn't lose your health insurance. But along with that came this need for privacy and security of your information, and that's what most of us think of HIPAA now, is a privacy and security law. It's very detailed. It's changed over time. 2 years ago, I guess almost 3, we got new HIPAA rules that talk about things like when you notify patients that their information has been lost. We're still waiting on some standards in HIPAA to be released, like minimum necessary. You know, how much information can you disclose? How much information do you need to access? So HIPAA is still evolving. It's a relatively young law, but we're seeing a lot of enforcement activity right now across the board. It's not just the big academic medical centers where this is happening. It's all across the board because, like I said earlier, patients know that HIPAA is out there, and all you have to do is Google it, and you can find the Office for Civil Rights, summary of it, and then it'll say, you know, here's how you can call one of our offices to complain. So basically what it comes down to is it requires covered entities to protect the privacy and security of individually identifiable health information by requiring appropriate safeguards to protect privacy. And it sets limits on the uses and disclosures of information without patient authorization. HIPAA does not use the word consent, they use the word authorization. It's just the world we live in. They want to be different. So HIPAA creates the rule of privacy. It grants individual rights similar to FERPA. You can request that your records be amended. You can request certain restrictions on your records. That's one of the new things that came out of the new iteration of HIPAA is that, say for example, you're covered by health insurance, but they won't cover elective plastic surgery, and you want to have a nose job, but you think that, you know, I don't want to run this through my insurance because I know it's going to be denied, it might raise my rate, something like that. You can actually request now that you can pay up front and that information not be disclosed to your health insurer. Well, why is that important? Well, if you have a complication, typically in the past, if you had a nose job and you had a complication, they would run the complication through your insurance and they would say, well, this was related to that nose job that you had that we denied, so we're not paying for any of the follow-up care. Well, this law was changed recently to change that so that, you know, that follow-up care, your insurer will never know if you paid for it up front and requested that they never get that information. Your insurer is never going to know that you had the nose job, so that they might not know that that complication relates to it, and they'll probably cover the complication. But that's, you know, it applies also to STD testing. So, you know, you think of like spouses who, you know, may or may not want their spouse to know that they had certain treatment. You can request, you can say, I want to pay for this all up front. I don't want you to run it through my insurance. And, you know, it's not going to show up on an EOB, so the other spouse isn't probably going to know anything about that. It requires structured remediation steps. So if you have a breach, you're required to do things to prevent that breach from ever happening again. It does impose consequences. There are civil penalties. They're being applied right now. The average for a HIPAA breach is about $1.5 million. And I will tell you that's nothing compared to what else you have to agree to do for the next 4, 5, 6, 7, 8 years. When you sign a settlement with the government, you agree to revise your policies every year and do training, and it costs much more than $1.5 million. Criminal penalties are also being pursued, not only from the HIPAA side of things, but you probably have state laws about privacy of data, and a lot of times people are using state laws in order to impose penalties on folks as well. There is no individual right to sue, so a lot of patients will say, well, I think my doctor violated HIPAA, so I'm going to sue the doctor. There is no individual right to do that. HIPAA is enforced by the federal government, by the Office for Civil Rights, the Department of Health and Human Services. Patients can complain to the department. The department will then choose whether or not they want to investigate it, and then they will show up and demand to see all your policies and ask for a long explanation of what happened, and then they can decide whether or not they're going to impose a penalty on you. But I say there at the bottom, remember that state law claims are also possible. This is what we're seeing a lot of now. State laws around the country are adding in protections for medical information and other private data. You've seen, you know, all of the Home Depot and all of the banks that have had the data breaches. Folks are now suing on the same theory for their medical information, saying you violated, you know, this. You said that you were going to protect my privacy under your notice of privacy practices. You know, you breached it. What happened? You know, and you have a state law claim of breach of contract or something like that, where folks are bringing state law claims against providers now in the HIPAA context. So just another added layer of complication. So HIPAA applies to covered entities. Most of you that are healthcare providers are going to be covered entities because you're healthcare providers who transmit health information in an electronic form in connection with a covered transaction. So if you bill Medicaid, if you bill private insurance, you're conducting what they call a standard or a covered transaction when you submit those claims. Just by show of hands in the room, is everyone billing Medicaid at their SBHCs and private insurance? Okay. All electronically? Okay. Yeah, so that's what wraps you into being a covered entity under HIPAA. It covers healthcare providers, like I said earlier, who submit these. That's institutional, non-institutional providers, hospitals, physicians. Dentists are covered by HIPAA. They a lot of times will say, I'm not a doctor, I'm not covered by HIPAA. Do you bill Medicaid? Do you submit dental claims to Medicaid? Yes. Are they electronic? Could be covered. And then other organizations that furnish, bill, or are paid for healthcare in the normal course of business. So HIPAA regulates protected health information, PHI, that's the buzzword. Similar to the identifiable information under FERPA, it relates to past, present, or future physical or mental health conditions, relates to the provision of health care, and the past, present, or future payment for health care. It's information that identifies the individual, or it's information where you can have a reasonable basis to believe the information can be used to identify the individual. So remember under FERPA that linking, it's the same thing under HIPAA. It's, you know, the fact that someone is a patient at your facility is PHI. I had a recent example in Nebraska. It was a rural town where there was a high school football game. One of the players was injured. It was a bizarre injury, but somehow he got a nail or something had gone through his leg. It was a very gruesome injury, and went to the hospital, had an x-ray. It made it to the newspaper somehow, a small town. Of course it made it to the newspaper. It was just the x-ray. It said, you know, look at this gruesome injury or something. And it didn't identify the patient's name, didn't say anything about who the patient was, age, anything, where they were from. But if you went to the sports page, 3 pages down, it talked about this player that had this terrible injury, that had this thing go through his leg. Well, it linked the two immediately. You know, big concern. That's a sort of outlier example that hopefully you won't see. But there's a list of all of the different identifiers. You know, it's not just name. It's you know, elements of dates. So, you know, dates of service, medical record numbers, email addresses. It's not just social security number, photographs, things like that. You've got to think that it's more than just name. Yep.
All right, what's a biometric identifier?
Biometric, so I believe, and I'm not a techie, so, you know, like fingerprints and
Retinal.
I don't know how much of this is in a medical record, but I guess there could be fingerprints. Although my new phone does have the little thumb thing on it, where it's yes, that's a biometric identifier. So the rule under HIPAA is that the individually identifiable health information is confidential and it cannot be accessed, used, or disclosed except according to an exception or in accordance with an authorization. So what are the exceptions? Because that's where we look to first. And folks always say, is there an exception? Do I really need to go get an authorization? And a lot of times, if you're in the back room of a clinic or a hospital or an SBHC, you won't need an authorization to do things like treat the patient. So if you're a hospital or a physician or a provider and you want to call another provider about, you know, either a future referral or care that's been provided to a patient, there is an exception. You don't need to get the patient's authorization in order to talk to that other provider. This happens a lot. I don't know how much it happens in your context where you have them calling outside providers, but it's an important exception so that you can provide care efficiently and in a timely manner to these folks. So I also want to mention remember going back to the example of talking to the school nurse. A lot of folks think that disclosure falls under this exception where the SBHC could talk to the school nurse about, an asthma plan or about what care was provided or medication administration instructions. It probably fits in this exception because the school nurse is a healthcare provider. The trouble that we have is that usually the information is going to go beyond the school nurse. It's going to go to the teachers, it's going to go to counselors, it's going to go to administrators, and that's beyond a provider-to-provider treatment disclosure. So if that's just going to the nurse, I don't necessarily have a problem with it, but it's anything beyond the nurse when you're going outside of the provider-to-provider treatment context that you have an issue, and that you probably no longer have an explicit exception. The next exception probably doesn't apply too much in your context, but the payment exception, where you don't need the patient's authorization in order to disclose for payment or to support payment purposes. So here you think about, if you're trying to coordinate benefits or figure out, which insurance to run this through, or if you're talking to the insurer, those are all protected under the payment exception. Importantly here, minimum necessary does apply, so you're not disclosing the whole medical record to coordinate benefits. I mean, there's not really a need to ever disclose all of that information. You have to really look at what information do we need in order to obtain or support payment for this service. So a lot of times it's, what service was provided at this other facility so that we can code it correctly or something like that. You're never going to need to disclose the full medical record in order to get that information. Healthcare operations, you probably do this in the background more. You're talking more about peer review, quality improvement. What's important here is that if you come to the afternoon session, we'll talk about program evaluation. Program evaluation can be considered a healthcare operation if you structure it correctly, and so you may not need the patient's authorization in order to do some program evaluation activities, but it has to be program evaluation. It has to fit within the definition of healthcare operation. I don't want to. What?
Can you give an example of that?
Healthcare operations?
No, program evaluation.
For what we did in Omaha, that falls under our associate agreements. We did a program evaluation of our school-based health center services and its impact on academic outcomes. And we actually linked the EHR with the academic record on an individual level, reporting at an aggregate level the outcomes, but it was to really look at, because everybody that, when we started the school-based health centers, the idea was we want to know if we're impacting health outcomes. So that was one of the things we did look at in the program evaluation. But the second thing we looked at was, is it having any type of impact on GPA, attendance, and a few other things we put in there to see, is there some connection? Are we moving the needle on academics in general? And under the rules of that, there is limited release of information publicly. So as opposed to when you have a research project or a program evaluation, and it's really going to be something that turns into lots of publications, and some researchers are going to write this up as an article, ours stops internally. Mm-hmm. So it's truly
it's like a quality improvement. Right. It's our report. We're evaluating our own program. It's not a researcher that's going to publish a national article on it with all the data. So other exceptions that are common, required by law. So think about child abuse reporting. You're all familiar with the rules there. You have an exception under HIPAA. You don't need an authorization. You have a mandatory reporting obligation. It's required by law. HIPAA is not going to trump that requirement. Authorized disclosures for public health activities. A lot of times will have to make reports to the state about communicable diseases that you've seen or statistics. That's also accepted under HIPAA. Health oversight activities. If you're being audited by the government, if they're coming in and wanting to audit claims, or if you have a Medicaid investigation, you have exceptions under HIPAA where you can disclose the information. Judicial and administrative proceedings. A lot of times healthcare providers will get subpoenas in a variety of different cases. You have an exception where you can disclose the information pursuant to that subpoena. But what's important is HIPAA has specific requirements of what has to be in that subpoena in order for you to rely on that. And folks get tripped up on this all the time. They get a subpoena that's very general, that's possibly signed by a judge, or in Nebraska, judges don't have to issue subpoenas. Attorneys can issue them. They'll be missing a lot of the information that's required. I mean, you have to have assurances that the patient has been notified that we need your information. We can't use de-identified information. If you want to object to this, you can go to the court and object. But all of those things have to be in a subpoena. So, in order for you to disclose without the patient's authorization. Law enforcement activities, we'll talk about this in a little bit, but know that there is an exception where you can call law enforcement in certain situations. And then going along with that, this exception for disclosures to avert a serious threat to health or safety. That's an important exception under HIPAA, that there are some requirements that you have to meet in order to disclose, but it's a very helpful exception for the case of like the scenario where we talked about the child that has cut himself and that's threatening to use a weapon at school the next day. So other than that, you do have to have an authorization. Psychotherapy notes require an authorization. You probably have policies on what constitutes psychotherapy notes, where you keep them. Other activities like marketing or sale of PHI requires an authorization. The authorizations do have to be specific. They're like a FERPA consent, where it talks about here's the information that's going to be disclosed, here's the party that we're going to make the disclosure to, here's the purpose of it, and it does have to be a standalone document. HIPAA requires that it cannot be combined. That trips up a lot of folks too. They combine it a lot of times at the bottom of their consent to treat. You cannot combine it with a document. It has to be a standalone document. Yep.
I thought the omnibus rule prohibited sale of PHI.
It doesn't prohibit it. You have to have authorization in order to do it. And sale of PHI could be for many different purposes. I mean, you could be selling a practice or selling a facility, and then PHI goes with that, so it's technically sold. There's an exception for that where you don't have to get an authorization. But if you're selling your PHI in order for somebody to market, you have rules on that, and you do have to get authorization for that. Like I said, the important thing here is that it's a standalone document. We have to counsel clients all the time to say, look, I know that you don't want another form, but if the regulators come in and they say, well, why did you make this disclosure? And you say, well, I made it pursuant to an authorization. Here's the authorization. If it's combined with something, they're going to ding you on it. So could it be on the back of a form? Maybe, but that doesn't become a standalone document if it's on the back of a form. The concern is that from a HIPAA perspective, that they were going to say that, you have to sign this authorization in order for us to treat you, and they didn't want to tie the two together to make it, a condition. So, yep.
Does HIPAA regulate or specify how long that authorization needs to be good for?
It doesn't state the time frame. You have to state it in the authorization. That's a required element of how long it's going to last. It can be until I die.
Right.
It can be for a specific number of years. It can be based on an event. It can be, until my cancer treatment is completed.
But
it does have to be specified. You have to talk about it in the authorization. Yep.
So you don't have to put a date. You can just say.
It doesn't have to be an end date
until prosecution is done.
Right.
Okay. And my other thing is, I didn't see where law enforcement is tied to HIPAA rules. We're not a CI, is that correct?
You're not a covered NB. No. Well, you might not be. I mean, I don't know. Maybe you provide healthcare services and bill for them, treating inmates or something. I don't know. But, required by law. I talked about this. This is in the exceptions. The most common. This is one of the first ones we looked at. Is the disclosure required by law? Mandatory abuse reporting is the biggest one under this category, where you don't need the individual's authorization because it's expressly authorized by your state statute or regulation or licensure rules. that you have to make the disclosure. So that's when we look to law enforcement. You still have to have authority. A lot of times in the hospital context, what happens is, like I said earlier, especially in a motor vehicle accident investigation, law enforcement show up, and I don't want to be rude, but you have your uniforms on and they are demanding the information, and people are shaking and saying, I've got to disclose it because he has a badge and a gun and I've got to just give him the information. Well, unfortunately, in Nebraska, going back to our little conservative state in the Midwest, some of our law enforcement officers are pretty pushy and stand there and demand the information, and I get the call saying the officer is standing here demanding this information, can I give it to him? First question, well, what's it for? Why do you need to disclose it? What are they, do they have an investigation? Well, no, they're just, they just want to know, they think that this patient showed up the other day seeking drugs. Is the patient a fugitive? Are they what's the purpose of it? So you still have to have authority under HIPAA to disclose PHI to law enforcement. So I say up there, can you call them and tell them that a drug-seeking patient showed up? Why? Do they have an investigation? Is the patient a fugitive? What's the reason? Can you tell them that a patient is going to injure a current or former patient? So here's the authority that we usually look to. First of all, crime on premises. You can disclose PHI if you believe in good faith that there's a crime that is occurring or has occurred on your premises. For example, I say the narcotic-seeking patient versus medical identity theft. If you're in a community that has a lot of immigrants, they may show up trying to use someone else's identity because they don't have insurance and they want to use someone else's card or information in order to obtain services. You arguably have medical identity theft, a crime. I don't know, in our state it's a crime, I don't know in your state if it is, but you have a crime being committed on the premises. You can call law enforcement to tell them that this crime is being committed. If you have a narcotic-seeking patient that shows up at your premises, or hopped in Nebraska, they hop around from rural hospital to rural hospital, but is that a crime? May or may not be depending on your state law, but in Nebraska, there's no specific state law that would say that this is a crime that's being committed for this person to show up and seek drugs now. It's going to vary from state to state. The other authority that we look to is this disclosure to avert a serious threat to health or safety. This is probably the exception that applies more in the SBHC context, and we've gotten some clarification from the federal authorities on this in response to the Virginia Tech incident and the movie theater shootings, where they've said, look, if we have spotted this and could reasonably have prevented this, you can make the disclosure, but the requirements are that you have a reasonable belief or a good faith belief that this is necessary, that the disclosure is necessary to prevent or lessen a serious threat to the health or safety of a person or the public. So what are they saying? Do you really think this is going to happen? Is it imminent? And then the disclosure has to be to a person who can actually prevent or lessen the threat. So it's not just calling everyone. Do you need to call the person's neighbor, and tell them that but it depends. Is the neighbor a target of the threat? Do they need to get out of there while you know that this person is en route back to their house? And the advice from the government in the past couple of years has been, look, we want to encourage communication to law enforcement. We don't want HIPAA to be a barrier. But they also caution that, not every situation warrants a call to law enforcement. There will be times when you don't have a good faith belief that this is an imminent threat that's going to happen, that this is just something that the person has said, or it's, not a huge threat, but you have to make the good faith determination, and most of the time it probably is going to be, when you're calling, the threat is usually big enough where you do need to make the call. Want to move into minor consent issues. You all seem pretty well versed in your minor consent laws in this state. It's so different across the nation. We talked about it a little bit earlier. What minors can consent to. Some states, it's just STD testing. A lot of times their statutes don't mention HIV or the definition of an STD. doesn't include HIV. Most providers across the nation feel that if minors can consent to STD testing, that includes HIV. It makes sense. Pregnancy testing, for example, in Nebraska, our statute allows minors to consent on their own to STD testing. It is silent on pregnancy testing. A lot of providers rely on the STD consent statute to do pregnancy testing, but it's not. It's a gray area in Nebraska. It doesn't sound like it's so much a gray area here. And then drug abuse and alcohol counseling, same thing. So the important thing under HIPAA is that HIPAA allows the minor to actually be the individual if the minor is authorized by state law to consent and does consent. So then, it's the minor who controls access to the records or who can sign the authorization to disclose those records. However, it's state law dependent because state law may permit the provider to talk with the parents in certain cases. And I'm hearing that in Oregon that you're permitted to talk to parents in certain situations if you use your reasonable judgment. So that, that's dependent on state law. But without that sort of a law, it's the minor who then controls the information in there. In Nebraska, I talk to folks all the time who say, look, it's, I don't have to treat this patient unless I want to under this statute. They'll a lot of times say, we're going to require your parents to consent. The parents will sign the parents will consent to the STD test. The result goes to the parents. That's a discussion that has to be had up front with the patient, and it sounds like a lot of you have that discussion with the minor and what their rights are and where you're going to make the disclosures here, so that's very good. And we talked about the explanation of benefits. A lot of times when minors come in and consent to treatments, they don't, they'll say, I'm covered by my parents' insurance, I don't want to pay for this, run it through my parents' insurance. Well, the parents are going to see the EOB, and they're going to call and say, what was this test? What was the result of it? I didn't include a slide on it, but HIPAA has a limited exception for disclosures to family and friends who are involved in the patient's care or involved in the payment for care. However, that disclosure has to be related to that person's involvement or to their payment. So, think of it as a spouse who calls up and says, well, I want to know what this test was about that I see on the EOB. And they're involved in the payment because it's their insurance. Well, do you need to tell them everything about the results and what test that was? Probably not. You can probably say for their purposes of paying for this, you can say, look, a lab test was done. Or a lot of times we call up the patient and say, do you want us to even tell the spouse that information? Or will you sign an authorization so we can tell them what the results were? But that applies in the minor context too, when a minor might come in and pay for the service on their own. Or, I don't know if any of you offer that. Do you offer that as an option to the minors to say, if you want to pay for this up front, you can then request that we don't disclose it to your parents? Do you guys offer that as an option? Or if they're running it under their parents' insurance, do you tell them that it's going to be seen on the EOB? Because that's, in Nebraska, Medicaid doesn't issue EOBs, so it's not so much of an issue because that's a lot of the population that we see at the SBHCs.
It kind of depends. Like, we do, if they have state insurance, then we do tell them that if they're wanting this to be a confidential visit and they have state insurance, we can bill the insurance and the parents won't ever know. Mm-hmm. If they have commercial insurance, then we do tell them that it can be a confidential visit, mm-hmm. and then they don't get billed out for the services. Yep. And the parent therefore would know because we don't bill their insurance. Okay, good. Yeah, so that's just something to think about in the EOB context, because I don't know what's on every commercial insurer's EOB, and it raises a lot of flags to parents when they get these. So I want to get into breach notification before we talk about some of our examples, just because this is a little bit more fun. This is not so boring.
And this is something that even though you're not in the hospital, not in the clinic setting, you're still gonna, have any of you had a breach where you've had to report it to the patient? I mean, no one's perfect. I mean, that's the reality. Is I was working with a client last week that was they were submitting documents in response to an investigation, and one of the questions is, in the past 5 years, how many breaches have you had? Because you have to report these breaches to the federal government through their website, and their answer was none. And I said, you've never had one other trip mistake where you've had either employee who's snooped, or you've sent the wrong bill to somebody, or I was talking with somebody 2 weeks ago, and they had sold all these old desks from the hospital. Well, the desks were built really poorly, and all these records got stuck behind the drawer, and the purchaser of this desk went to go move it, and when he moved it, all these paper records fell out, and it was all HIPAA authorizations. And I mean, these things happen. Like I said, nobody's perfect. They happen from time to time, and there's a process that you have to follow now. So a breach is, the covered entity, you're required to notify the individual of a breach, and then you're also required, like I said, to notify the Office for Civil Rights. If you have over 500 individuals that are affected, you'll not only be immediately investigated, but you also have to make notification through the media, which is always a little embarrassing, and nobody wants to do that, but it happens. But sometimes that's why you have to count every single breach. The one that I was working on that I mentioned about last week involved 482 individuals. We spent a week, literally almost 24/7, going through the records to figure out how many do we have, and we got to 482 and said, at least we're not at 500. But the Office for Civil Rights is investigating. So what's a breach? Acquisition, access, use, or disclosure of PHI not permitted under the privacy rule that compromises the security or privacy of the PHI. So you really have two things going on here. First, you have to have a violation of HIPAA. So what happened? It was an inappropriate access. It was an inappropriate disclosure. It got mailed to the wrong person. I mean, you first have to have the HIPAA violation, and then you have to ask yourself, did it compromise the security or privacy of the PHI? And that's the new standard under the new omnibus rules that came out a couple of years ago. The previous standard was there a risk of harm to the individual? Well, the government said, look, we never said anything about harm. We think that's too big of a barrier. We don't want you to use the word harm as a standard. The new standard is, was the information compromised? So what do you look at? You look at 4 different factors. You look at what information was disclosed, who was the recipient, was the information actually viewed or acquired, and then was it mitigated at all? Did the recipient destroy it? If it was a misdirected fax, what did they do with it? Did they delete it? Did they shred it? Did they send it back? I could talk for hours about this process, but you probably all have sort of an incident response plan where you go through maybe asking these questions. Say you misdirected a fax to a grocery store rather than the grocery store pharmacy. It goes to the central faxing station at the grocery store. Well, factor number 1, what was it? Well, if it was prescription information or medical records, you have a lot of PHI. Who was the unauthorized recipient? If it was the grocery store, they're not covered by HIPAA. They're probably not covered by other data privacy and security laws. Maybe it's different if it went to a bank who has privacy and security laws. I mean, if it went to the wrong doctor, probably covered by HIPAA, maybe okay on that factor. You can't stop if you get a favorable response to 1 or 2. You have to keep going through all of them. Was the PHI actually viewed or acquired? Hard one, but if you sent the wrong bill to a patient and it was, Anna Armstrong at my address, if I didn't open that envelope and physically walked it back to the provider and said, here, I got this, it came to my address, but it's not my name, but I hadn't opened it, that's a pretty good fact, because I probably didn't look at any of the information other than her name on that letter. And then the extent to which it's been mitigated, that's sort of the same thing. You can look at, if, was the fax sent back? What's your, like at my office, the process for receiving faxes is it goes to our central receptionist, it then comes to my office, my assistant. At that point, you've got a lot of people that could have looked at that fax. If I delete it, it doesn't get deleted off of our system. It goes into my deleted box. Did I go into the deleted box and delete the deleted item? You know, you have to think about all these things because otherwise that PHI is still out there for me to view. And you have to do that for every one of these incidents. It's a big task. It's a hassle for your privacy officer and your compliance folks, but these things happen, and like I said, you probably have a process in place and sort of an incident response plan for responding to these incidents. Examples. I could go on and on and on and on and on about these. Lost laptops, misdirected faxes, leaving records in plain view, failing to shred them, access without a treatment relationship, social media. I mean, you name it, it happens. And it simply goes on. This is from my personal Facebook page. My friend lives in Guam and is a dentist and posted this, and I don't know if you can read it. It says, saw this patient today. His front wheel came off of his bicycle while he was riding it. I don't know what happened here, but anyway, it's something bad with his mouth. And, you know, the next question, the next comment is, and you referred him to? I mean, you can see this isn't necessarily a HIPAA violation because I don't know who it was. I don't know where she works. But I'm guessing that if somebody around there on the military location where they lived knew that a kid had this bad accident, you can reasonably identify who this kid is and who this happened to. And the fact that people are now commenting, and you referred him to, but I mean, what are the other comments? I mean, is she going to comment back, say, you know, I referred him to the hospital here, there? I mean, you can see where this is a landmine. Hopefully you have strict social media policies for your providers. Here's just a few quick examples. These are of bad cases. This is a doctor in Michigan. She was the associate medical director of the ED, posted a picture of a patient on Facebook. A nurse posted the picture. The doctor commented, "Is that TB?" Initially, the physician was just removed from a leadership role. They later decided that it was serious enough. She was terminated. So was the nurse who posted the picture. That's the standard now for these types of posts, is immediate termination. You know, these things, you see them in the news all the time. Going back a couple years, mustache that went viral. Anesthesiologist drew a mustache and put stickers on a patient's face. Nurse posted it on Facebook. This actually resulted in a state investigation and a civil lawsuit against the anesthesiologist. Again, the patient wasn't privately suing under HIPAA, but they were trying to recover some damages based on this incident. Cardiology nurse incident. This is a common example. It comes up a lot. You had a nurse that her duties included looking at lab results and preparing patients who were referred to this cardiologist for their appointment. She had signed acknowledgments of her HIPAA training, but her mother was a patient and her sister was a patient at the clinic. So she took it upon herself to access their records, 44 times of her mother's, 28 times of her sister's. They did an audit of her access to medical records, standard procedure at most places where they'll audit your access. And they saw this and they said, well, the mother and patients weren't current patients. They didn't have an appointment. They didn't have a scheduled appointment. They weren't coming in. They didn't sign an authorization. She wasn't their power of attorney. And they went and asked her, and she had no problem with it. She said, well, they're my relatives. She was immediately terminated. She brought a suit for wrongful termination. Obviously, that went nowhere because she wasn't. And, you know, she was, doing this, and who knows how many times this happens for other places. You know, you have celebrity clients. Ebola patients come to Omaha now. Same thing. The medical record is easy. It's accessible to everybody at the med center. We had patients snooping on Dr. Sacra's records while he was in the Ebola unit at UNMC. They were immediately terminated. What's interesting is that it made the news that they were terminated, but they also had to write a letter to this physician saying that they had snooped through his records. So there's no exception just because you're an employee of the facility and you have easy access and you might know the patient, or if it's family. or you're the employer and you want to look at one of your employees' records if they were seen at the clinic. You have to have a purpose to look at the information. You have to have a purpose to disclose it. The exceptions, as we just talked about, are all very narrow and exclusive, and the sanctions are significant. You don't want to be in the middle of an OCR settlement and negotiating whether you're going to pay $2.5 million or $1.7 million and agree to 8 years of compliance reviews and things like that, when you could have prevented this through a lot of training, a lot of reminders. You have to be creative in reminding people that HIPAA applies, and sending out periodic reminders and examples like I've included on the slides there. So educate and train your organization. Let them know that their access will be audited. A lot of employees don't realize that we are going to have a trail of every record that you've looked at, and you better be able to justify why you looked at these records. I was working with an organization where one of their finance folks was snooping through records of family members, and we said obviously that's not permitted. She was fired, but the process after that was, now when a finance person goes into the record and looks at it, we make them notate why they were in the record on this certain date, because it's hard to, when you read these audit reports, it's hard to know, well, did they have a legitimate purpose? A lot of times you can look at the date of the access and the date of the patient's appointment and figure out, the two correlate. But it's good to just address it within your organization all the time and let them know that snooping is not permitted. I don't know why folks still think that they can just go through and look at all their patients' records with no treatment relationship, but it still happens. Last 20 minutes, we just sort of want to put this all together and encourage, again, some more participation. We want to share with you a little bit more about what we do. We've already shared a little bit about how the information flows in the Omaha SBHCs. I mean, it's different everywhere. We were talking, like I said, last week with a group from Chicago. They're very sophisticated in their processes, and they take some aggressive approaches. There's not a right or wrong approach to this. I would encourage you, if you have questions after this session, either talk to us afterwards, but talk to your organizations. Figure out what your process is. If something's new to you or you don't know what the answer is, ask your administrators. Ask your lawyers. You can tell them that I sent you. Ask anybody who might help you get through some of this. Ask if you have a policy on it, so that you know how to follow it and implement it. Because that's the most important things that you can take from these presentations, is some of the examples and some of the conversations that you've had amongst yourselves to figure out, well, what do we actually do on this? They brought up something that we think we do, or we think we have a process or a policy for, but we just don't know exactly what the details are. It's a good time to go back to your organizations and start sorting that out. And then, of course, you have all of summer break to get it perfect, right? So information flowing from the school to the SBHC. What you want to ask yourself here is, are you disclosing information from education records, or is it directory information only? Because that's going to go to whether or not you need FERPA consent. So look at what are the, what's the information? Is it immunization information? Is it disciplinary records? Is it attendance records? Is the access through the information system? Are they logging in remotely to the school system to see certain pieces of the information, or tabs, as we have in Omaha? We'll mention in a second. Big question, do you have a FERPA consent? Do you have the parents' consent or the eligible students' consent to disclose that information to the SBHCs? And when do you get that consent? That's a big issue. We all know that it's hard to get parents, in a lot of cases, to sign the forms. We have a big issue with that in Omaha. You have parents who maybe aren't as active in their child's education. For example, we have a very large Karen population in Omaha, where their parents really don't take an active role in their education. And so getting them to sign a consent form and understanding the importance of that is a timely process. You can send something home in the kid's backpack, but you're probably not going to get it back for a majority of the students. When you talk about the opposite, when you talk about the SBHC information going back to the school, are you inputting it into the information system? Are you faxing it? Are you just communicating it back? Are you even communicating any information back? A lot of SBHCs don't. They just don't talk to the schools. But that usually doesn't work because you want to talk to the school nurse, you want to talk to the teachers. So, you know, who do you need to talk to? On Anna's side, on the program evaluation, you know, are you going to be disclosing information to administration or to the teachers or to the nurses, like I said? Again, you have to look at what's the purpose. Are we doing it for treatment? Can we fit it in that narrow exception for treatment? If it's only to the nurse, if it's to the teacher, it's probably not a treatment purpose, but you know, can we get an authorization? Or same thing with administration. You're outside of that treatment exception, and you probably don't have another applicable exception. You know, if you're talking about just disclosing treatment records back, not an emergency, not one of those examples, but you know, why do you want to disclose the information? What's the purpose of it? So you need to think about that. And then, do you need an authorization? The answer in most cases is probably yes. And you know, you have to fill out that authorization of what's the purpose, what's the information. You know, again, going back to the consent process, when are you going to get that authorization? Are you going to get it up front, right when they enroll in the SBHC, or are you going to get it every time that you need to make the disclosure? That's probably not likely. That's harder to do. So you can get it in advance, but it's just something you need to think about in terms of your process. And then a big question: have you discussed it with the parents or with the students? You know, as part of the enrollment process, do they know about these SBHCs? Do they know that information is going to be shared back and forth? As part of our enrollment process, which we'll talk about, the parents are informed that this information is going to flow back and forth. So in our example, we have Omaha Public Schools with all of our centers, which they have the brick and mortar buildings that house these SBHCs. We have One World Community Health Center and Charles Drew Health Center, which are both federally qualified health centers in Omaha. One of them serves the population in North Omaha, one of them serves the population in South Omaha. What they do is they do get a FERPA consent up front as part of the enrollment process each year at the school district, and it says that education records, it lists out certain types of records that will be disclosed to the SBHCs. Emergency contact information, IEPs, attendance records, accommodation plans, and some other very limited pieces of information. And the way that that works, and we took a very long time to set this up because the school district is very proprietary about their information, is the SBHC providers do actually have access to the school's information system. They log in and they see, you know, these very small pieces of information that they have access to. And that was a very big hurdle to overcome with the school district in letting them know, you know, what is our purpose in getting this? Have we informed the parents up front that we're going to allow this? Do we have their consent? And so as part of the consent process, when someone enrolls, and this goes to the school district's information management folks, but when they enroll, that's the trigger to then turn on that access. And if they don't ever get the enrollment form back, you know, the access, you know, you're not going to be able to access that student's record. So it's a very sophisticated setup on the information system, and I realize that not every school district is going to be able to have that same setup. I mean, OPS has a very sophisticated information system where they were able to build in all of these protections and separate out all of these pieces of information to allow this. But it's a big process. It's done as part of the school enrollment process. Each year it goes out with a huge packet of information. It goes with parents. As Anna said, they also have a lot of educational tools that the parents can get more education about this process. What you want to think about is what's the duration of the consent. Do you want to talk about that at all?
The enrollment form.
Yeah.
Yeah, and I think I mentioned it earlier. It goes out if the child's in elementary school. Once they've completed it one time, they're enrolled for the time that they're in elementary. So when they go to the next school level or outside of that elementary building, they move, then they have to do a new enrollment form. So what happened was they were doing new enrollments every year. I think this is where this came from. So it was like 50,000 enrollment forms coming in and going to the school district that some poor soul had to toggle these kids on in the system, and they said, wait a second, that's what they wanted, the school district, and when they realized, oh my gosh, we don't have the manpower to handle this, let's do a one-time enrollment, and immediately that slowed down. And so it's only those new students that are new to the school district, or those new students who are making that transition from elementary to middle, or middle to high school.
And the consent form does include a statement that says they're consenting to their child being treated at the SBHCs. The SBHC providers were very cautious, and they said, we don't want to take that as our consent to treatment. We're going to get a separate consent to treatment. That, I understand, is a very common example. The Chicago SBHCs, for example, take a different approach. They do not get a separate consent. That is the consent.
I think they don't actually contact the parent until they are ready to treat. And it's just to inform them that their child's going to be treated.
So it's a different process, but that is the FERPA consent. It talks about the information that's being disclosed. It also talks about our minor consent laws in Nebraska. It says, the school-based health centers will typically contact you to inform you of your child's visit, because it's not going to be all the time if you have a high school student who comes in for STD testing. So we literally looked over every single word in the consent document. I mean, the form is big, the margins are small, it's one page, we wanted to keep it on one page, but we literally have gone over every word in that consent document to make sure that it's accurate. So that is a big part of the process, and it helps to periodically look at those to make sure that they're covering everything that you do and addressing things like minor consent. Like I said, in Omaha, they do get a separate consent to treat. If the parents are unavailable, they'll usually get a verbal consent and then follow up with written consent. That's what a lot of healthcare providers do in our area. I'm sure that's common around the United States. They also get a HIPAA authorization when they are getting the consent to treatment at the SBHC. And that HIPAA authorization authorizes disclosure back to the school district of certain information. It may include just limited information about their visit or medication instructions. Sometimes they are entering some information back into the school district's information system, but that's how we get that disclosure to go. Is it saying we're going to talk with the school district, because it's more than just the school nurse. It's to the administration, it's to the counselors, it's to teachers potentially who are going to see some of these notes or information about the visit, if they're adding to immunizations, things like that. So we do get the authorization. It's a separate document that's signed at the time that the child consents to the treatment at the SBHC. Research and program evaluation. We also have started doing this now. There are detailed rules in HIPAA about it. We talked about healthcare operations. We were very careful not to call it research. Research is very different from program evaluation. Anna can give you a brief explanation of the difference.
So for us, the important thing was really, and why we went with evaluation, besides that it meets some of these criteria, is that it really was what made our partners comfortable with the idea that we were going to look at student data, both from an academic side as well as their health records. And the whole idea was to look at process, look at outcome measures, and look at potential areas for improvement. It was a tricky thing because it also, a lot of people hear evaluation and it kind of puts a bad taste in their mouth because they think, oh, you're going to shut us down. And that is the no kidding response we got from some of our providers is, are you going to close our clinic if we're not doing what you think we should be doing? No, not at all. We're about improving and doing what we do better. And so for us, it was an easier case, and also an easier way to approach doing this type of work was, we're going to keep this information within the school district and the federally qualified health centers. This is not going to be public release. This is really truly to make sure we're doing what we intend to do. We're reaching the audience that we're intending to reach. We went in thinking we want to make sure the services we're providing are getting to our target audience, but that they're also using the services in the way we intended them to be used. So for acute care, not to become, we really don't have a model where we're like medical home. So this was what we were looking for, as well as for the school district's interest. They wanted to know, are you helping our kids do better? Are they in their seat? Is there more seat time? Is their attendance improving? So evaluation was different. If we would have gone the research route, and we did use university evaluators, they're from the local university, and that was a process for them to understand as well, because they were mostly assistant professors who would have really benefited from a bunch of publications to get on their tenure. But they were willing to do this. I mean, we obviously paid them, but we didn't have to go through an IRB process at the university. We did go through the school district's process, and there's still some tricky things that happen along the way in terms of the type of data you're accessing. I think the biggest win for us that I can share is that through this process, because a lot of trust was built, we are now allowed to have student identification numbers loaded into our electronic health records. And the school district is providing that in basically a data dump that can be linked up with our existing health records, because they know long-term we do want to see how these students perform, and that will make it one step easier. And that's a big hurdle for a lot of school-based health center programs.
Mm-hmm. So when you think about it, we've just listed some questions there, which you need to address. Given our time, I just want to revisit some of our scenarios and just see if you have any other thoughts on these. You actually did very well on the pretest, so there's probably not a lot that has changed, but we'll just throw out a few more issues. So go back to scenario 1. This is the nurse who refers the student. The SBHC wants to communicate back medication administration instructions. And then the second example was the teacher who contacts the SBHC for information. We said under the first scenario, do we have a treatment relationship? Potentially, but did you get the authorization? That's probably the safest route to go, is get the authorization from the parents in order to talk with anyone back at the school district, whether it's the nurse, whether it's the teacher, administration. That's the safer route to take, and that's what most places I think do in order to talk back with the schools. Scenario number 2, that's the student who's injured and says that he's going to hurt the teachers. We all agreed that this was a health and safety emergency. You're talking about a disclosure from the SBHC, so you're talking about HIPAA information. Remember the exception for disclosures to avert a serious threat. Do you have a reasonable belief that the harmful threat is imminent? If so, is it a disclosure to someone who can lessen the threat? So law enforcement here can likely lessen the threat. The parents may be able to. The school may be able to, depending on the facts. But I think we all agreed that this would be a permissible disclosure. Situation number 3, this is where the minor had consented and paid for the STD testing up front. The parents saw the prescription and called asking for information. You would look at your state law regarding permissive disclosures to the parents. If you would also look to HIPAA, to the fact that the minor consented to the treatment, and if the minor had paid for the service up front and asked for a restriction, can you still honor that? What if they saw the EOB? We talked a little bit about that. What are you going to tell the parents if they see the EOB? It may be we're not going to tell you anything because that's our policy, or maybe you're involved in the payment for the care. We can tell you same as what's on the EOB. There was a test done. But a lot of that will also depend on your individual facility policies on how far you're going to go in response to one of these calls from a parent asking about payment information. Situation number 4, the principal wants to evaluate the outcomes. We just talked about that. Where are you going to get the information? School districts do similar things. We hired the local College of Public Health to do program evaluation on behalf of the school district. So no need for a FERPA consent. The issue there was we thought if this was research, we're going to have to talk about the IRB potentially. We're going to have to talk about going and getting consent from parents. We have enough trouble getting consent. We're never going to be able to get consent if we have to do that, and if the IRB wouldn't waive consent. Same thing with HIPAA authorization. If we can't get an IRB to waive this authorization. How are we going to get HIPAA authorizations going back a couple of years from all of these parents whose children were treated? Situation number 5, that's the gas station stop. That's the fund breach scenario that we talked about. Obviously, the information is protected by HIPAA. You would notify your privacy officer immediately, or the other individual at your organization that is supposed to receive these reports. You would roll out your incident response plan and work with administration to correct the violation and make any necessary reports or notify individuals. So with that, I know we have just a little bit of time. If you have questions, feel free to ask publicly, or you can come up and see us. If not, thank you for your time. 3 hours flew by, and we really appreciate you guys being so interactive with us. We learned a lot from you guys.